Good morning. Today we are going to talk about neurobiology of oral and facial pain. So we know the oral mucosa and the facial skin. The function of them is just to protect the body from physical and chemical damages, infection, dehydration, and heat loss. That is the basic function of any external covering. So when we see the oral mucosa, compare oral mucosa and the skin. What is the difference? The skin has hair follicles and sebaceous glands, whereas oral mucosa has taste buds and minor salivary glands. So the oral mucosa, regarding the permeability, the oral mucosa is more permeable than the facial skin. And in the oral mucosa, the buccal mucosa and the floor of the mouth has more permeability. That is why we use medications or drugs to get absorbed in that area more quickly than the other areas. And one more thing is oral mucosa heals after injury faster than the skin without a scar tissue formation. So this is the basic idea of oral mucosa and orofacial skin. When we talk about the peripheral nociception in the orofacial tissues, it occurs through peripheral branches of the trigeminal nerves. We know the trigeminal branches, the first branch, second branch and the third branch, ophthalmic, maxillary and the mandibular. So how does this sensation is taken to the central nervous system? So we have the nervous system, the sensory receptors here. The sensory receptors, the cell bodies lie in the trigeminal ganglion, and from the trigeminal ganglion, the neurons, second order neurons, they go. And already as mentioned, the head and neck region don't have spinal tracts. They have a spinal nucleus tract. So we have the spinal nucleus in the brainstem. If you see the spinal nucleus, it is divided into portions. It is oralis subnucleus, interpolaris subnucleus, and caudales subnucleus. In that, the caudales subnucleus receives the second order neurons from the trigeminal ganglion, and from there the information is relayed to the thalamus, and from the thalamus it goes to the cortex. The last seminar we had mentioned about the somatosensory cortex, insula, cingulate, and frontal cortex. All these somatosensory for the location and intensity of pain, whereas the frontal cortex, it displays the emotional part of pain. So this is how the pain is perceived from the orofacial tissues. So this is what is mentioned here. So we have the spinal nucleus, which plays an important role. And coming to somatosensation of oral mucosa and facial skin. What is somatosensation? All the thermal, mechanical, heat pain, cold pain, pressure pain, all those things, how they are sensed in oral tissues and facial skin. So regarding the thermal and mechanical sensitivity, the oral mucosa differ from the facial skin. So extraoral skin and the tongue tip are generally more sensitive than the gingival mucosa. Here they are comparing the extraoral skin, tongue tip and the gingival mucosa. In that, gingival mucosa is less sensitive than the tongue tip and extraoral skin. And the face and tongue are more sensitive to cold, warmth and mechanical stimuli than the gingiva. Coming to chemical stimuli, which is really more sensitive, like facial skin or the oral mucosa? Obviously, oral mucosa is well developed to detect various chemical stimuli with considerable sensitivity. So when we apply certain chemicals like capsaicin, mustard oil, cinnamaldehyde, or even menthol, there are different sensation which is perceived. So the topical application of capsaicin to the oral mucosa produces a burning sensation. The topical, what happens, the oral mucosa, it leads to strong pain from the, so after applying capsaicin, if you apply heat in that area, it will cause more pain at the site of application as well as in the secondary area. This is called as primary hyperalgesia at the site of application, and outside the site of application we call it as secondary hyperalgesia. So this happens in oral mucosa. How about mustard oil and cinnamaldehyde? They also enhance the pain caused by application of heat. Mustard oil and cinnamaldehyde themselves are chemically, they cause burning sensation, and on top of that, if we apply heat, there is increased pain sensitivity. And they modestly enhance the pain caused by the application of cold to the tongue. Even if we apply cold, that also causes some pain in that area. And menthol, we know menthol causes a cooling effect. So menthol injection increases both warm and cold detection thresholds. It increases the threshold means the pain perception will take more stimuli to get stimulated. So, but it does not affect the pain intensity in response to subsequent heat or cold stimuli. So there is no change in when we use menthol infusion. So this is regarding the chemical stimuli. And what about the heat pain? Heat pain is to some extent we can bear the heat. After that it develops as a pain. So that is heat pain. The heat pain threshold is higher in the gingiva, while the mechanical pain and vibration detection thresholds are lower in the tongue and the other tissues. So heat pain, the threshold is more, which means we should not confuse that it will cause more pain. It is threshold is a level above which the pain will be stimulated. Below which the pain, even if you use the stimulus, it will not cause pain. So heat pain threshold is higher in the gingiva. Paradoxical heat sensations upon cooling do not occur in the skin or tongue but occur in the gingiva. What is paradoxical heat sensation? It is opposite to something which we are stimulating. So when we give a cooling effect, it causes a paradoxical heat sensation, which means when you apply cool, you should feel the cool sensation. But contrarily, it causes a heat sensation. That is paradoxical heat sensation, which happens in gingiva, not in the skin or the tongue. So this is shows that the gingiva has a poor thermal discrimination capacity. So this is about heat pain. And when we talk about pressure pain, what is pressure pain? To some extent, our skin can hold the pressure, but once it exceeds the threshold, then it turns into a pain. That is pressure pain. The pressure pain threshold is lowest in the tongue and highest in the face. And there is no difference among the oral mucosa and facial skin in terms of cold pain threshold. So responses to cold and warm stimuli are poorer in the oral mucosa than in the supraorbital skin and nasal mucosa. So when they compare the supraorbital skin and nasal mucosa, the cold and warm stimuli, the responses of is poor in oral mucosa. So that was about the somatosensation of oral mucosa and facial skin. And when we talk about the properties and projections of primary afferents in oral mucosa and facial skin, oral mucosal mechanoreceptors exhibit both fast and slow adapting properties. So the stimulation of fast adapting fibers produces sensations of vibration, whereas the stimulation of the slow adapting fibers produces sensation of constant pressure. So this is the difference between the fast and the slow adapting fibers. However, there are no fast adapting mechanoreceptors with the properties of preceding corpuscle afferents in the oral mucosa. And based on their conduction velocity in the oral mucosa, the nociceptive fibers can be A delta or C fibers. A delta fibers are 58% and C delta fibers are 42%. And based on their responses to thermal, mechanical, chemical stimuli, oral mucosal nociceptors are classified into 4 types. That is A delta high threshold mechanoreceptor nociceptors, A delta mechano heat nociceptors, A delta polymodal nociceptors, and C polymodal nociceptors. And the mechanical threshold of each of these receptors is higher than in the skin, whereas heat threshold is similar. And 40 to 45% of buccal mucosa afferents express a receptor called TRPV1, which we discussed in the last journal. It is a receptor which is a receptor for the nociceptive stimuli. And it also has a TRPA1 receptors which may transduce the burning pain caused by capsaicin and mustard oil. So since buccal mucosa has the maximum number of these pain receptors, it has the sensation of burning pain due to the application of some chemicals like capsaicin. And TRPMA, and with the last discussion we talked about this receptor, which is a cold sensor. So which in the oral mucosa, like immediate sensation due to menthol. So menthol has a cooling effect. For that sensation, this receptor is activated. So trigeminal nucleus caudal neurons are